Hello, this is Amjad Al-Mandilawi from Baghdad, Iraq, presenting the third series of coronary intervention in CTO. This presentation is concerned with retrograde technique. The case is a 50-year-old male, smoker, not diabetic and not hypertensive, with stable angina, scheduled for PCI to the RCA. This is the alloy view of the RCA, shows a mid-total occlusion with TIMI flow 0. Angiography of the left system in the same projection shows a good retrograde flow. So whenever we face a chronic total occlusion, we have to clarify several points, and this involves the stumps, both the proximal and the distal, the length of the lesion, and whether there are bends inside the lesion or proximal to it, calcification, adjacent branches, the size of the distal vessels, and the presence of collaterals. We also have to estimate one of the scores that determines how difficult the procedure will be, and one of them is the CTO score. In our case, the stump was blunt, given a score of 1, calcification was absent, the lesion length was more than 20 mm, there was no bending more than 45 degrees, and this was the first procedure, so giving it a total score of 2 with a high difficulty. Generally, there are 4 techniques to deal with CTOs, and usually a combination of any one of them in the same procedure can be used. Our plan was to go for antegrade wire escalation, and if this failed, we can go for retrograde technique. Antegrade dissection and re-entry was another option, but we lack the equipment for that. So a trial of antegrade wiring done, and this failed, and the wire was extraluminal, as can be seen by retrograde injection. Here we cannot overemphasize the importance of bilateral injection in every case with CTO. So we went to look for collaterals, and there was a large branching septal artery giving collaterals from the LID to the distal RCA. We passed the proximal part using workhorse wire and a fine cross MG microcatheter, then did a tip injection which showed the course of the collateral. Then the collateral was crossed by Sion wire, but it could not be followed by fine cross microcatheter. This is the tip of the fine cross MG microcatheter, and we can see the guiding catheter is pushed back whenever we push the microcatheter. So what to do when the microcatheter does not cross? We can increase the guide catheter support, or take a guide extension catheter, change the microcatheter, or do some anchoring. Although the fine cross MG catheter is a safe and a good microcatheter, it's not very much pushable and is not torqueable. The Corsair has a tapered end and gives more support, and you can rotate it about 10 times in both directions, both clockwise and counterclockwise. So we changed the guiding catheter into the AO, Amplas left, and changed the microcatheter to the Corsair. And this should have been done actually from the beginning. We crossed the distal RCA, we crossed to distal RCA and did tip injection. Then the Corsair microcatheter was pushed up to the distal part. And now, what is the next step? Here we have several options. One is to use it, the retrograde wire, use it as a marker for antegrade crossing. This is not always possible, and actually it's very rarely possible. The other thing is retrograde crossing from the distal to the proximal, going through the lesion, i.e. intimal tracking. And the third one is a reverse cut, where a dissection done antegradely to create a false channel, and this one is crossed by a retrograde wire. Our preferred method is retrograde crossing whenever possible. Once the microcatheter reaches the distal cap, the wire is exchanged for a CTO wire. That is a harder one, and here we used the Miracle 6. Always, you have to take orthogonal views to make sure that the wire is in the correct direction. And here you can see they are meeting in the same plane. And here we can see the retrograde wire has crossed the lesion and we pushed it up to the antegrade microcatheter. Now, what is the next step? This is in another view. What is the next step after crossing retrogradely? There are two options. You either do externalization, where you externalize the wire through the antegrade catheter. In this case, you need a long wire like RG3, which is around 330 centimeter long. Or use the tip-in method, which is again our preferred method because it's easier and it avoids externalization of the wire. And that's what we did in this case, and we'll explain. To do that, we have to push the microcatheter all the way to the proximal vessel and preferably to the antegrade catheter. You can see here we pushed it up to the antegrade catheter. In this is not always possible as it needs a great support, and in this case we needed to anchor the wire of the retrograde catheter by balloon in the antegrade catheter. Once the retrograde microcatheter inside the antegrade guide, it's not difficult to push an antegrade wire into the lumen of the retrograde microcatheter. You can see how we are aiming here at the tip of the microcatheter. Once you are inside the microcatheter, this means that you have converted the procedure into an antegrade one. The retrograde gear can be withdrawn. The lesion is treated as usual with pre-dilatation and stenting. And this is the final result. Of course, before withdrawing the retrograde wire, you have to make sure that there is no injury done to the antegrade, to the donor vessel. In conclusion, retrograde technique enhances the chances of success for CTO procedure. There are multiple steps to be done to complete a retrograde PCI. A good toolbox should be available in the cath lab to ensure success. And thank you.